Hello, I'm Dr. Marla Shapiro, professor in the Department of Family and Community Medicine at the University of Toronto and on the Board of Trustees of the North American Menopause Society. I'm so pleased to have with me today Dr. Andy Kaunitz. Andy is a University of Florida Research Foundation professor and associate chairman in the Department of Obstetrics and Gynecology, University of Florida College of Medicine in Jacksonville. Welcome, Andy.
Nice to be here.
So for the practitioner looking at contraception in perimenopause moving forward, what are the safest contraceptives that can be used and when should we be stopping?
So in general, for all women needing contraception, including younger premenopausal women, IUDs are becoming more and more popular, and with good reason. They are effective. They don't require women to remember anything every day, so they're very convenient. And they also have important non-contraceptive benefits, which are particularly important for perimenopausal women. The progestin IUDs can be used by essentially all perimenopausal women. There are a few exceptions, for instance, women with abnormal shaped uterine cavities, but the great majority of perimenopausal women, regardless of medical comorbidities, for instance, are appropriate candidates for the hormone-releasing IUD.
So that will also help women who have heavy flow. What about once the hot flashes begin to kick in? Is it time to remove the intrauterine device or not?
In fact, once vasomotor symptoms or perimenopausal hot flashes start occurring, women who have a progestin IUD in place are in a very good place indeed, because we can simply add oral or transdermal estrogen, and women can continue to have the contraception as needed, the menstrual suppression, and then with the estrogen, effective treatment of hot flashes with good endometrial protection from the hormone-releasing IUD.
So when we look at midlife women who may have a contraindication to estrogen, be it a former blood clot or whatever it may be, would this be a good candidate for them then?
Exactly. So women, for instance, let's say they're in their 40s and they smoke, or they're hypertensive. These women are not good candidates for combination estrogen-progestin pills, but they're excellent and safe candidates for the progestin IUD. And often we can even use low doses of transdermal estrogen to treat hot flashes if that becomes appropriate down the line, where contraceptive doses of estrogen might be contraindicated, let's say because of older woman who smokes or hypertension, comorbidities like that.
And what about if you've got a woman who insists on being on the birth control pill? She's happy on the birth control pill, she doesn't want to get off her pill. How do you manage these women? When do you start beginning to think about, am I masking menopause symptoms? Just a brief word on that.
Sure. So a woman, let's say, who's in her late 30s and now in her 40s and doing well on oral contraceptives, and as you implied, these women are in no rush to stop the pill because they have minimal withdrawal bleeding, they feel good on the pill, they're good pill takers. As long as this woman who's now getting into her perimenopausal, let's say late 40 years and beyond, as long as she is a lean, healthy, non-smoking woman, she can continue oral contraceptives right into the menopause. No gonadotrophin testing, no FSH or estradiol testing is appropriate. And in my practice, I'll continue right until mid-50s. By the time a woman like this on oral contraceptives attains mid-50s, her likelihood of ovulation off the pill is so low that at that point she can either transition to no hormonal management or to the lower doses of hormones used to treat hot flashes in postmenopausal women.
Thank you so much for joining us today.
Thank you, Marla.